the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Good morning, George. It's Tuesday morning, and we're going to tape another podcast today.
Yes, today we have Dr. Rani Jarandi, and the topic of discussion is going to be artificial intelligence in medical education, now and the future.
So, as you all know, I'm a big fan of Nicholas Children's, and particularly the Nicholas Children's CME department. They will be hosting their annual CME Conference for Postgraduate Pediatrics in Southern Florida this year, around March 20th. Unfortunately, after about 10 years, I will not be able to attend this year, but I encourage everyone to attend. Today, we're diving into the most transformative and controversial topics in healthcare education, artificial intelligence. How is AI reshaping the way we teach medical students and residents? What opportunities does it unlock for research and publication? And critically and ethical guardrails that need to be navigated in this new frontier. To guide us through this complex landscape, we have an exceptional guest and friend of the podcast and a personal friend of ours, Dr. Rani, who is the Director of Medical Education and designated institutional official at Nicholas Children's Hospital, clinical professor and vice chair of research and graduate education in the Department of Pediatrics at Florida International University Herbert Wertheim College of Medicine. With his extensive experience in both clinical practice and medical educational leadership, Dr. Rani brings a unique, informed perspective on how AI is transforming and challenging the way that we teach the next generation of physicians. Rani, welcome back. How are you?
Thank you so much. I'm doing great. Thank you, George and Herb, for having me back, and great to see you. I'm doing well.
With all those degrees, I guess that's why you have all those diplomas on the wall. With all those titles.
And Randy, what's new and exciting, and what venue is the postgraduate course going to be held at this March?
We are holding it at the same place as we had last year at the Hilton Marina Resort in Fort Lauderdale, and it's on the Intercoastal Waterway. It's going to be, like you said, March 20th to the 22nd, the weekend, and hopefully, some people during spring break, they could combine the spring break together with some education. Yeah, we're looking forward to another year. It's our 61st annual postgraduate course.
Unfortunately, I had to pick between being with you or being in Medellin that weekend. And
well, I don't blame you being in Medellin.
So I think I'm going to stay in Medellin for the weekend.
Yeah.
Is there any lectures that are, that you're particularly excited about?
Yeah, we have, obviously we do always try to bring a combination of practical common stuff. So like we have this year, IBD, short stature, dermatology, school of psychological screening and dermatology, but also we do have some hot topics. AI used in the practice management is going to be one of the topics. Obviously, disinformation in social media and communication with the families is another one. AAP Red Book editor is going to be featured as well. And then exciting as well, some genetic testing and personalized medicine. You probably heard about the new gene related to anesthesia complications in patients from Venezuelan descent.
Yes.
So being in Miami, we've seen quite some number of patients here, and having the pediatricians there needing to be aware of it when they talk to families who have kids who are going under anesthesia as well. So we're excited, and then obviously we have Florida has just passed a law requiring pediatricians to screen with an EKG for clearing athletes from 9th grade and above. So a lot of pediatricians are kind of figuring out what to do and when to do it and how to do it and who's going to read it. So we're also having one session on that as well, clarify some of those issues.
So can I just send those patients to Nicholas and you'll do the EKG and the cardiologist will read it, or?
Well, yeah, Nicholas Children's since 2011 has done before even was a requirement, has done a free EKG screening program in the community, and they go to schools and they go to communities. So currently the EKG, yes, the EKG is the screening is free and with the reading as well. Now, if the child needs a little bit more a workup because of abnormalities, then they could be seen in the clinic. But yes, absolutely. And they're working a lot with community schools and making kind of mass screenings on site. So the patients,
Wow.
so pediatricians will be feeling at least they're not really overwhelmed with the numbers of patients.
Yeah, because I mean, I'm not going to buy an EKG machine.
Yeah, that's exactly. And there is, I guess, an international guidelines that are different for reading the EKG because and that's what our cardiologists are going by, which is like Italy has had screening for athletes with EKG for a long time. And otherwise it's different than if basically the machine reads it automatically. Speaking of AI, sometimes it actually, there might be an overdiagnosis or over maybe exclusion of patient students from playing sports because then you start the cascade of, and it might be normal. So there is a little bit of nuanced diagnoses.
That
Sounds
sounds
like
like, yeah, it sounds like a real headache to implement.
Yeah. And then now it's, it's gonna, it's passed through Florida legislature. So that's like the Florida chapter is also working. We're working with the Florida chapter on being part of the Florida chapter, and the treasurer for the Florida chapter. We're working also on having some of those, figuring out what's the best way to actually implement it without making it onerous on the pediatricians.
Yeah. So that's like, I'll have to read up on that, but that sounds like it's going to be difficult. And then the kids can't play unless that EKG is in there, right?
Yes. Yeah. Now, if they revise the form that if the child had had an EKG in the past, I think 2 years for other reasons, the pediatrician, but then you'd have to like pull the record, find that, the pediatrician has to attest that they don't need one because they've done one in whatever date and it was normal and it was read by so and so. So it's a little, yeah.
wow.
Oh, wow. All right. Well, and that is EKGs have been using computer intelligence for decades now, right? That's where you get that readout.
Yeah.
So that brings us to today's topic. And what AI models are you and your students using today, and why?
That's a great question. I think the students, young generation, are using a lot of ChatGPT, maybe open evidence when it comes to like similar to when you're trying to ask, up to date about, needing a quick answer. And then Claude is another one that's being used in the medical education arena. However, having said that, the hospital, in our hospital, ChatGPT and those are blocked because there is always a risk of having inadvertently people put PHI and violating HIPAA, whether it's, data on patients, whether you're doing a research and you're putting patient data. So actually what the recommendation for our institution is, and a lot of institutions are going that way. We have a homegrown AI tools called Ask Nick, which is kind of our homegrown, done by our IT department. And it actually goes out to the web and search the same way ChatGPT does and gives you the information, but it is secure. And even IT, sometimes I heard that even the IT guys use it to, if they need a code and if it's a junior IT technician and need a code to they could ask it and it gives them the code and to code something in IT. So usually the recommendation is either to use a proprietary in-house type of thing that's secure, or I've heard before that some of the ChatGPT and the subscribed one, and some of those apps that you not free, they might be a little bit more secure. And some institutions are using that as an institutional kind of.
Yeah, ChatGPT has the paid up version, a higher one that is HIPAA compliant and secure. But I thought that once something is pushed out to the internet, the search, that's when the security issues start. So even if, they're doing, Ask Nick, if it's going out to the internet, then it can't be secure. I don't know. But I heard about this last year, Dr. Igor told me about it at a conference, there's this thing called Chat Labs. where that thing searches, but it only searches within your website. So if you have links to, designated, like American Academy of Pediatric stuff that's on your website, all that stuff, it only searches within your website. So that keeps it secure and keeps it from going outside and keeps it from getting all the urban legend and anti-vaxxer stuff and all the weird stuff.
Yeah. I mean, I would say maybe, probably nothing is totally 100% secure.
It has not.
But definitely, to go back to your question about what the students are using, I think, sometimes even though it could be blocked in the hospital, but if you're on your own device and you're on your own phone and you're using cell signal, not really, you're not connected to the internet, you probably can go to ChatGPT and other.
Yeah.
So they're using a lot of this. However, there was a study that was done that surveyed 207 students about their use of AI. And it looks like around 2/3 of them use ChatGPT from the different vendors, but mostly the majority are using them as the same way you use Google. You Google something, it's like a search engine, which is usually most of the times, and I'll talk a little bit later about the prompt that you need, but sometimes when you use it as Google, like the way you ask Google, many times you might not get all the response that you're looking for, or maybe there is higher risk of hallucination.
So let me ask you a question. When do you need institutional review board approval when you're doing research? Like if I'm just looking at retrospectively at, my experience screening with EKGs or for diabetes, do I need institutional review board approval for that?
Yes, like a retrospective chart review requires IRB. However, it will be either an expedited review or it could be sometimes quality improvement projects, sometimes are exempt, but they still are reviewed by the IRB to give like the stamp of approval that it is exempt. Or if it's an expedited review, they just have to see that the data that you're using are de-identified, that you might be, let's say you're looking at hemoglobin A1Cs of patients and so there's no other way from the data that you're collecting, there's nothing to track it back to a patient. Still needs IRB, but more to get like an exemption, because especially if you're going to publish it or do a poster or something, a lot of those organizations or journals want to see a letter of exemption from the IRB. So we still require, we still recommend to our trainees to actually, because a lot of them are doing it because they want to present an international meeting and they want to share that. So we say just upfront, just get the IRB approval for exemption.
And then retrospective studies don't have patient consent, right?
They don't have patient consent, especially if you're not really using any identifiers. So we do have, for example, at the hospital, we do have certain divisions have databases that will actually strip from the EMR the data, the identifiers, and put it in a different database. And that database get an umbrella IRB approval. So then if you're always mining that data, you don't need a full protocol. You just need to tell IRB. So it's a quicker way, because if you're only not going outside that data, the one that require more full IRB approval are more the prospective randomized trials and, clinical trials.
And then case reports don't require IRB.
Usually no, technically they don't require IRB. We do have, some of them, we do have a consent for the family, because sometimes a lot of those cases are very rare. And if, let's say, even though we published one case of this diagnosis, technically the parents might, if we don't tell the parents might be able to trace it back and say, this is my child, because
because it's such a rare disease process.
Yeah. So we get that approval.
And then, do you know your IT team, what did they train the Nicholas Children's AI on?
I really don't know, but I know that they had encouraged us to keep using it in the beginning to kind of, even though if we're not getting the answers we need, in order to kind of get it more and more trained. For example, I don't use it for a lot of things, but I use it for our meeting minutes for the GME committee. So technically we use Zoom, and we have the Zoom AI transcriber, but now we put it into AskNick. We take the transcription and put it in AskNick, and with a template, and I figured out the prompt to tell it what I need to tell it. And, I wanted to put it into, here's the agenda, and I wanted to put it in this format, and then have these 3 columns. It comes out, the minutes come out the way we used to, the coordinators used to type them. So now the coordinators will do a first run on them. And I noticed that getting better and better, the output from AskNick for that, the more we do it, that it's getting better. We have to check it all the time and make sure that the information that it listened to and took is truly accurate to what happened.
But doesn't Zoom provide that service already? And it's HIPAA compliant.
Yeah, Zoom provide. We used to use the transcriber, but it comes out as more like, so and so said that, and like almost like a word by word for word, almost like you're dictating.
Oh no! Now they have the new thing called AI Companion that does all that stuff.
That's a summary. That's a summary. Yeah. So we use that because it summarizes the themes, but AskNick puts it, actually, it comes out, all what I need is just to kind of put my signature in, because it comes out with the categories that are on the agenda in a table format, the way I asked it to.
Yeah, that's good.
Yeah. So it's interesting because there are open and closed models.
Mm-hmm.
And so, for example, Open Evidence uses Claude as their model. That's what's on the, they didn't create a whole new AI. They just lease Claude and give it a single use. And then they closed it. And by closing, I mean Open Evidence only looks at peer review published reports. So they're not looking at, what Herb Bravo said about this 10 years ago. They only look at things that have been peer reviewed and published. So what the output you get when you're searching for, and it's HIPAA compliant,
Mm-hmm.
so you can actually put a whole patient's chart in it. Well, there's a limit to 30 pages, but you could put it and say, summarize this cardiology consult for this patient. What was the diagnosis? What are the things I need to do? And is there, is this evidence-based? And it will tell you, like, this patient has this, and you're supposed to do this, and here's 5 articles that are peer reviewed to tell you why you should do that. Because it's closed, then it's more accurate. Right.
Yeah.
And
I've been using that. There's another one. It's called Doximity.
Yeah.
That's also a HIPAA compliant thing. Everybody has that, and it's free, along with Open Evidence. I've been using that with the students, where we take the discharge summaries from the big hospital. They give you loads of garbage to read. So just trying to find a hepatitis B vaccine, or simple things, the birth weight, the discharge weight. How these people made all these progress notes impossible to read. You drop it in there and you ask it, summarize this, keep it towards just the medical information, social information, vaccinations, and it gives you a nice summary of what happened. Problem. One of my doctors, when I showed it to him, he felt that, oh, this is really, really good. I don't even have to write a progress note. He wanted to copy, cut, and paste into the chart. So he started doing that. And then I would print it out and have the paper with me and actually review the note. So this way I'm looking at it and speaking it and telling the student and telling the parent, and it's getting picked up into the medical scribe. And then that's my note.
Mm-hmm.
I found that if you're not looking and not reading it, you can introduce wrong information into the chart, and then you're responsible.
Yes. Yes. You're absolutely right. You're absolutely right. It is. Yeah. It does hallucinate. It does give you, it's trained to actually, I heard that and I was like, okay, that makes sense now. It's trained to please the user. So if you ask something and does not have the answer, it just makes it up.
Yeah.
And it looks cool. It looks right. It looks like there is a reference and there is to give you an idea. I am on several editorial boards of a couple of journals, and we've been getting manuscripts with references that don't exist. And, so, a manuscript will have 20 references and then 12 of them don't exist at all. And they have a DOI number. They look on first glance, they look cool. So now as a reviewer, we didn't used to like double check the references for every reference to see if it exists. But now it's almost like you have to, because especially if some journals have had where you attest that you used AI or you acknowledge the use of AI, but some of them, you don't disclose. If they don't ask, they don't disclose it. The author doesn't.
Yeah.
Disclose.
So we'll touch on that a little bit later, but yes, so I have to, Grammarly is a spell check, AI program. So I have to use that and I still misspell things. I run everything through an AI model if I'm going to present it, because I can't do grammar or spelling and it's still wrong. But when I'm writing an article on something, I write it, then I put it into open evidence. It gives me the references, and then I have a subject matter expert review the references, and then we go over which one, because, like in the diabetes space, you could get 3 different references for where the staging started. And I always want to go back to the 2025 ADA reference, not any other reference. And so the reference actually may exist, but the AI model is giving me the wrong reference for that. And so, but it does help me write, which is what I need, but it's not without a human. The other model, which I find even more useful, is something called Notebook from Google.
Oh, yeah.
And so Notebook from Google is really a closed model. I don't know if it's Gemini is their backend, but it only reviews the things that you give it to review.
Right.
Okay. So if I wanted to review the subject of EKGs for sports as a screening tool, I could bring the 5 articles that I think are, the most important articles, give it to it, and then give it a YouTube video of a presentation by a cardiologist in Italy, and it'll read it. And then I can ask it to summarize it for me. And, but I'm controlling the data that's coming in. And it blows your mind, because obviously it can see things that you might miss because you get distracted when you're reading the article, and present it to you. And that's a very closed off model. But, for when you're really wanting to look at medical data, you choose what it sees.
Yeah.
And then, but that takes wisdom. You got to know which are the articles that really inform that topic to give it to it, right?
So Ronnie, you get it this one. So I work with the 3rd year and 4th year medical students from NYIT. And when they come in, like the first day, in the first couple of hours, they're all scared. They don't know what's going to happen. And I tell them, and you're going to have a presentation or a discussion about a topic that we'll find a case in the room. So then I'll go and I'll look on Google and I'll find the most complicated topic about inflammatory bowel disease, for example. 40 pages, very research based and everything. So I'll drop it inside there. And I'll tell them, and here's the article, but you're not allowed to prepare more than 30 minutes for this. And they look at me like I'm insane. So I drop it into the Google Notebook. It gives them a little podcast. They listen to the article a little bit. It's summarized. Then they have the summary notes, and I allow them to have the summary notes to be able to speak. And now it has a cool thing, this infographic about the podcast. You could, about the article, you could actually do a whole presentation with that infographic. Herb has the best infographics for his lectures that I've seen in my life. And
so Randy, so when I was a young kid, I asked my mother for a Casio calculator for Christmas. It was a block. It could add, subtract, divide, and I think maybe do percentages. That was it. And it was LED, and it ran off batteries. And she said, no way, no how.
Okay.
You will become dumb. You have to know your summation tables, your multiplication tables. And I'm like, this is stupidity. Why do I have to memorize all of that? I already know that. I can do it faster with a calculator. No, my dad intervened and I got it for Christmas. So is AI the equivalent of that Casio calculator back in the 70s And is it going to make the medical students dumber than they already are?
That's a good question. And there's a lot of concerns on by when, because a lot of, people might say, what about clinical reasoning? What about, even, think of the EMR. Now, we were in the generation where we used to write on paper and we used to calculate the doses and to write the prescription. So, if there is a downtime for our EMR and you go back to paper for a day, it's no big deal. But the residents who've never done paper, they get really like flustered what to do now. There is something actually called the risks of de-skilling or never skilling. So you never acquire the skills. And that's something being looked at from the education literature about when medical schools, for example, should introduce AI, in different stages where maybe you want to introduce AI as the safe use as a tool, like the same way you use a calculator or you use a fax machine or any of that. But it showed that actually there is more risk of either not acquiring the skills or losing the skills if you introduce it too early. I'm thinking maybe Med 2, you're in the classroom but then if you put students in Med 3 where they are actually in the clinical space and they never get to try to use the data that they learned in Med 1 and Med 2 to actually generate a differential, or they're going to rely always on the AI tool to generate a differential. Sometimes there's going to be a bias from the AI tool because they might get a differential that's totally biased and they might not, or they might get a whole litany of stuff that's, maybe in a, as a, when you're yourself trying to think through something, you're kind of, even though your differential include 10 things, but you say, okay, the top 3 things with this patient are these diagnoses. AI doesn't know that. It gives you the whole things from the literature and it gives you the tons of things. So there is a fear that those students who don't know how to differentiate see the forest from the tree, they're going to be bogged down with trying to like almost rule out everything on that list. And then you're going to actually be either biased to call something that's not true, or you're going to be overdoing stuff to diagnose things. So there is I guess there's always, it's still early, but a lot of the AAMC came up now with some guidelines related to AI use and how to kind of trying to introduce it at the end of the day, you cannot even skip it because they're going to get to residency and they're going to see people using it, but so it might be too late. So it's almost like, when is it actually appropriate to use it and to what degree? And I think the consensus, there's no consensus yet or like guidelines, but what I'm seeing more and more is you want the students first to get to a stage where they acquire those skills so that they can, to your point, what to feed it, if you see an output, you can actually say this is not right. But if you don't know, you've never those skills, you're going to actually just believe it and run with it.
So I guess year 1 and year 2, they'll still do it old school. And then clinical years, they'll start using all the different things. Yeah. I can see that.
Yeah.
With students.
I think that Course has left the gate. I think Epic has made all the new doctors really dumb. I'm so sorry, but I'm going to say it how it is. Their critical thinking skills have deteriorated because they follow whatever pathways and alerts Epic says in their institution. And they don't do critical thinking. I had my dad's cousin passed away in January, and he was in his middle to late 90s, but he had esophageal cancer 15 years ago. And somehow someone still left that on the Epic problem list. And that GI guy that was taking care of him writes in his note, patient with esophageal cancer, advanced age, should consider only palliative care. Right.
Wow.
And that's the problem when you don't talk to the patient and you don't examine the patient and you don't have critical thinking skills. You just pull and accept what's in Epic and what Epic pathway says and Epic alert says, and you're not doing critical thinking. We have a whole new generation of physicians that were trained on Epic And it's more dangerous at AI because Epic isn't thinking. It's putting whatever someone programmed to tell the physician to do. So I don't know how we get that back in the bag and we teach them to be critical thinkers.
Yeah. And then to your point, and George, since you mentioned that you have students with you, there are now recommendations. Obviously, the first recommendation is make sure that the students acquire the critical thinking skills first before introducing AI. The second one is to kind of train faculty to precept in the AI age. For example, like almost like think of when EBM started, and students will go get an article and then say, this child, I think this child has sinusitis. And then you start probing them, what makes you think that? What makes it, what test do you order? You want to order a CT scan or an X-ray or not, or nothing? And you kind of, so there are now recommendations that even if the student is using AI to come back with a clinical reasoning for the case, there is ways for the preceptor to probe for more, to try to actually assess that reasoning. Are they just regurgitating what AI said? So there is a framework called DEFT AI, which is diagnosis, evidence, feedback, teaching, and recommendation for AI use. So it's kind of like, what's your diagnosis? It's almost like a quick 1-minute preceptor. What's your diagnosis? What evidence do you have for this? And try to defend your diagnosis. You give them feedback, so at the teaching point, and then you kind of give them recommendation for AI use in the sense if they made a mistake or if they actually really were going down the rabbit hole, to say, here is how you can ask AI better to give you a better answer. So it's almost like you're saying that the cat is out of the bag. So we cannot ignore that it is there and it's going to be used. But at the same time, we just have to have those ways to not only teach, but also teach them how to use it, but also be able to assess their clinical reasoning even with the AI, to say what can they come up on their own. Maybe you could say, what if the child was 17 years old instead of 5 years old? What would you be different? What would be, so let's see if he knows more than when you go beyond the AI, to see if, so different ways of actually precepting. But at the end of the day,
But to train the preceptors first. Good luck with
I'll
that.
say you have to train that is the big thing about faculty development, because now the new generation knows more about AI than the faculty.
That's true.
I think we have to go back to the very basics, right? So when I was a medical student and I saw a case and say, it was pulmonary tuberculosis in a child, right? The diagnosis was made because they were already in the hospital.
Yeah.
But the attending would always say, and how do you know that? What did you read? Show me the article.
Right.
And then you had to go down to the library and fish through paper to try to find the article and photocopy it and bring it back the next day. And you better have read that article and understood the strengths and the weakness of the article.
Yeah.
So I think when somebody puts something into ChatGPT as a medical student, I would look at the first article it references and say, did you read it? What was the strength of that article? Where are the weaknesses? What level evidence did they use? Was it a randomized controlled trial? Was it retrospective or prospective? What weakness did the control arm have? What biases did it have?
Yeah.
Because you got to keep them honest. You got to keep them honest. And even if it's a simple thing like sinusitis, what level evidence is there that this is sinusitis and this is treated with amoxicillin and not with Cipro?
Yeah.
Right.
Yeah.
Why do you accept that answer?
Yeah.
Right. And I think that's the only way. We got to go back to the very, very basics so that they have critical thinking skills.
Exactly.
Unfortunately, the system does not help because the
Right.
system wants non-thinking physicians that do what the system wants. The squeaky wheel becomes they have a name for me in the hospitals, disruptive physician. They don't like it when you ask questions. You should fall in line because this is how we do it. Okay.
Put your head down and
and so it's difficult. But can AI replace wisdom, empathy, and the art of medicine and relationships?
No.
No. I know. I think even the AI, there have been some data on AI used to give bad news, to train about giving bad news or about things like that, approaching, for example, in medical education, if I am a faculty and I need to give a bad feedback to somebody and I need to be empathetic. Some faculty ask AI like how best to use it. Like I want to be harsh, but not too harsh, and I want to be this. At the end of the day, whatever AI says, it's in the delivery of that bad news, and it's in the empathy, it's in looking somebody's in the eye, it is in. So it might give you ideas of how to approach the issue, but it still needs that touch, and it needs that human interaction.
Human interaction, yeah. Otherwise, you have rise of the machines, like in the Terminator.
Yes.
You need the human factor.
It needs human factor. It's being used to kind of train people on a simulated to give bad news. So like if you're in an ICU and or a palliative care training in palliative care, and then you might be, AI could be, if you don't have money to get a lot of simulated patients or actors to play, AI could be trained to actually interact with you as a simulated patient and be, I've seen some data on using AI for training for motivational interviewing. And you can say, okay, I am the pediatrician and you're AI, you're the teenager who's I'm trying to convince you to stop vaping. Here is the 4 categories of motivational interviewing. And I'm going to talk to you and you answer me and be oppositional. You don't want to stop vaping. And I want you to grade me and give me feedback on how I did. So AI could do that, could actually play, and you can switch role and you can say, okay, now you play the pediatrician and I'm going to play the patient to see how you're going to actually counsel me. So those are maybe valuable because you can get, it's almost no different than when you watch a video and you try to do a role play or somebody. But in the real life situation, I think at the end of the day, you have to take that information, learn the skill, and actually put your personal touch to it. At the end of the day, it's still gonna be back to you and the relationship with the patient, to how you're gonna deliver that. Because AI is not gonna know that you took care of this patient since he was a child and now he's, I don't know, a near drown, and you're gonna tell the family bad news and how you're gonna actually deliver that. It's not the same.
So I think AI has a phenomenal potential, and I've read this several times in different industries, and I think they're right. People who do not learn how to use AI will find themselves out of a job. And I see it already in clinical practice. For example, I have a T1D kid who I've tested him for autoantibodies 3 times. They're negative. He's Modi's negative. And he is dysglycemic on 2-hour OGGT, dysglycemic on CGM, and hemoglobin A1C is 6.2. Okay. So I had to know that 10 to 20% of kids with type 1 do not have autoantibodies. But then when I fed that model, including a fasting C-peptide, to open evidence, it right away said, this is what they call atypical type 1 diabetes or idiopathic type 1 diabetes, which happens 10 to 20% of the time. And then it gave me a printout for the parent to take home, right? That's a beautiful use of it. Yeah. Another one is an adolescent female who's obese, and the owner of the practice ordered a 2-hour OGGT, and it's normal, but the hemoglobin A1C is elevated. And that happens, right? And I miss one thing. I just put the kid's BMI, like vitals and all the labs. I missed that the kid's anemic. And so that's a really good use, because the open evidence said it's not unusual to have discordant 2-hour OGGT and hemoglobin A1C, but this kid's anemic, so that causes falsely elevated A1Cs. So that's not a reliable result, right? And I know that, but I when I was looking through the labs, it escaped me. So those things I think you can, if you know what you're doing, what test to order, and you're just trying to summarize what you've seen, it's got tremendous power. Also has tremendous power for things that you don't see every day. Like I saw a kid with macrocytic anemia the other day. I don't remember the workup for macrocytic anemia. It just doesn't happen that often in pediatrics, right?
Right.
But it just says macrocytic anemia. Here's the decision tree. It quoted an article, showed me the decision tree, and this is what you order next, and this is what you look out for. So it has potential, great potential, but I think you have to have some wisdom before you start using it.
But they used to have those trees in books, Herb. I
I
remember
know,
they used
but you
used
first
to
have to
have-
recognize it was macrocytic anemia, which you
Yeah.
might miss because you're so used to seeing iron deficiency anemia. And
Yeah.
second of all, then you have to go find the hematology book on your shelf, which is probably 15 years old, and go to that chapter and, go through the freaking things until you found the chart. So yeah, it expedites that. So it's
It
like a book.
expedites. You know,
So here's a
you-
loaded question.
Okay.
So why bother with recertification, the ABPs? I can now have a chatbot created that answers those stupid questions, get it off of it, just send them money so they can live the life they want to live, and create an MOC for that is like what the pharmaceutical companies are doing. They're taking models and they're putting, if we do this and that, tested it in 25,000 virtual patients and they get output. So that's does that totally change what we should be doing as once we are already trained?
Well, I think a couple of reasons which you already mentioned about you need to know the background knowledge to be able to decide if that, because AI, the output from AI could be accurate and it could be not accurate and it could be hallucination. So you have to decide, you have to have enough knowledge to actually decipher what is real and what is actually hallucination. You also, as far as, you mentioned MOC and recertification or MOC4, which is the QI, it could help you with your QI. It could be a tool to help you because if you have the data and you give it to the AI and say, put it in a chart for me, give me the average length of stay for this data set or whatever. But you have to actually know what to feed it and what to give it to that actually is valuable for this QI project. You have to have some little bit of knowledge of the QI kind of basics. So at the end of the day, I look at it more as a tool, the same way the calculator, the fax machine, the internet, the web. But at the end of the day, it looks like what's showing a lot is if you ask it to do something de novo, with like most of the examples you guys as we're talking, you're giving is you gave it the article, you gave it the question, you gave it the content and said, fix the grammar for me or make it, more readable. That's actually great use of it because it's a tool. But I think what I see more, the danger of it is when somebody is asked to write, let's say, a manuscript and doesn't write anything and basically asks the AI, write me a manuscript on this topic, de novo, totally. So the whole content is created by AI. Then you have to have enough knowledge to actually double check it and make sure it is actually accurate because it could be totally off the wall. So you're still going to need that. Or maybe, I would say maybe one way, maybe the AVP or some of the certifying bodies could use it is to using AI so you do a set of questions and maybe even like residencies and medical schools could use it using performance improvement individualized by a person. So you answer questions or you answer a vignette and AI could tell you where your gaps are in knowledge. And here is a learning plan, or here are the, 20 questions about endocrinology because that's your weakest point, rather than everybody taking the same exam.
Yeah. The only problem with that is that, you have passions, right? Some people are passionate about this or that in practice. Like I don't feel comfortable with autism. I just don't. And, and so, yeah, I know that's my knowledge gap, but I really don't have an interest in learning about it. Have somebody else see that patient because I just don't feel like I can learn what I need to learn and the
Right.
science is not tight on autism. It's too nebulous. And I just think it takes years of clinical practice to be able to be good at helping kids with autism.
Mhm.
And I'm at the tail end of my career, so I don't have 15 years to learn about it. So it's an interesting question, and I don't see why, like when you can do predictive models with them with AI now, why bother doing chart reviews in your practice? Say this is what I do with them. Say I didn't know about smart genotherapy. This is what I do with an asthmatic. I put them on an albuterol nebulizer and don't follow them,
Oh,
right? And simulate 200 patients with that and tell me what the outcomes are. And of course, it's going to show me that the outcomes are not that good because they're not an
mhm.
anti-inflammatory. And now I go, all right, run it. If I switch it over to dual therapy, doing smart Gina at this dose, what would be my outcomes? And then it runs it and it tells me these are my outcomes. That's all I need for the quality improvement project. I now learn I got to change my practice, right? And that, I mean, honestly, that's what I need. I don't need to wait 3 years,
It
uh,
might go that way.
right? And so, do I really need to pay the American Board of Pediatrics ditto for that? No, Zippo. That's I need to learn to use this tool to improve my care, but I could do it in a couple hours. So it's going to be fascinating. I don't know how it's going to come out, but it's going to be fascinating. So, what do you think are some of the ethics and the use, both on medical education, research, and publishing? You touched a little bit on it.
Yes, definitely. One of the ethical issues, obviously, is basically having content that's not really, especially in publishing or in research, because that could be definitely, as it was mentioned, you're responsible for all that data or that manuscript or that information, and you're an author, and that's where the kind of the authorship. There's 4 categories that an author could, when a resident would ask, like, does Dr. So and so need to be on my paper? And there's like 4 different things they should have done. Like did they contribute to part of the manuscript, or did they actually part of the research itself? Or so there's a couple of, AI doesn't meet any of that. So technically AI cannot be an author. So one of the ethical things is risks would be for research or publication is actually having the disclosure or the acknowledgement. So those, I would say, for residents or fellows, I tell them usually you could put it in the acknowledgement that AI was used for, I don't know, grammar check. AI was used for generating this graph using the data from my research. So disclosing it is better than actually having it and double checking the output of the AI, double checking the references. And that brings me back to the prompt. I tell the residents that the key to asking ChatGPT about something is not just like you're asking Google. It has to be very specific, like doing a consult. If you ask a consultant, please see this patient, but you didn't give them any question that you have, you're not going to get the right answer sometime because they don't know what you're looking for. But if I ask the prompt correctly, usually there is a schema for the prompt. It has to have a role. So as an educator, for example, and I'm preparing, let's say, a manuscript, as an author for a manuscript, I am asking you to put this paper into, check it for grammar, put it into, 1,500 words, make it more readable. And at the end of the prompt, you have to give it instruction to say, don't make it up. If you give me anything that's outside the content of this paper, I want you to tell me where it came from. So it's almost putting some guardrail to even the AI not to hallucinate, because otherwise the AI would start telling you great things, and most people look at those ideas and they're like, oh, that's great, let me incorporate those. But those actually can derail you. The other thing one of the ethical things is making sure about the confidentiality and feeding AI things that are maybe, HIPAA risks or data that's maybe de-identified. And that's something not only in research, for example, some medical schools looked at using it for admission to the med school, like looking at personal statements. And again, that's risky because some of those applications could have, birth dates or security numbers, I don't know, like stories, personal stories that people tell. So it has to be a secure site, and it has to be making sure that you only feed the AI data that is actually have been de-identified and not put anybody at risk.
And there's also business processes and business intelligence as propriety. And you don't want that to be inform the AI model so your competition can use it. And that's a real thing. In medicine, we tend to share a lot of data on our processes, but business intelligence is very important.
Yeah. You know what I'm curious about, Ronnie? Medical scribing. I'm very into this stuff. Are they using that in residencies? Yeah, some residency programs there are. Where my son is, they're not allowed to. They're allowed to in the outpatient, but not in the inpatient. What's the story?
The medical scribe using AI or using a scribe?
No, medical scribe is yesterday's news.
Yeah, so now it's anymore. Yes. AI, we're actually not using it. We're piloting it in some certain outpatient clinics, and only by faculty for now, because they were trying to kind of see how well it's going to do, and it's perfected. Ultimately, probably some of the high volume, high acuity, high volume, where you need to move fast areas, will be probably implementing it even for the trainees. But currently, the residents are still using, just the regular, they're doing their notes, but some clinics are using it, piloting it, and we haven't started using it for.
Yeah, I'm using it in my office. We've been doing it. How long have we been doing it? 2 years now, right?
Probably, yeah.
Probably about 2 years. When the students come in, we use it. It has helped with communication skills upon the student, the presentation skills, the interaction with the patient skills. That seems to be developing.
Yeah.
Rather than typing away on the computer. So when they come in, it's so funny. Each and every student comes in, he sits down on the computer, he's ready to jump, to type. I tell him, stay away. Use the computer to look at the problem list, use the computer for med list, allergies, things like that. Use the AI scribe for the rest of the visit. And then by a week or so, they're in, they're talking, they're engaging, they learn how to be a doctor.
Yes. I think that have been a very good outcome of using AI in the clinical setting to help you with the kind of the administrative work that was taking people away from being with the patient at the bedside.
Right.
And that actually, I think that should be probably modeled definitely for new generations of learners, because, for a while we everybody was a scribe. And not really looking at the patient. So I think
and a cashier. We were turned into a scribe and cashiering, so the health system can make the money it needed to pay the salaries. That's how the HR was assigned.
But I have to emphasize that the physician still needs to review that note that gets put into the chart, copy, cut, and paste. And I don't agree with the ZHRs that are building it in natively, where you can, because this is what will happen. It's going to take it. It's going to be really good. You're just going to push a button, drop it into the EHR, and not even going to look at the note. You're going to introduce some bad things by accident. At least the copy, cut, and paste piece of it makes it a little bit, it's a step to prevent rise of the machines.
Right.
Yeah.
Right. And it is important to realize for the user to realize what can go wrong, so that actually you're watching for it. Maybe it's going to get, in the future, it's going to get even better and better. And probably ChatGPT, for example, now is much better than what it was a few years ago. But at the same time, there are some guardrails that need to be in place, and definitely be looking at the output itself and making sure, double checking it, because at the end of the day, you're signing your name. This is your work, and you have to take responsibility for it.
Yeah, guardrails to rise of the machines.
Yes.
So I think one area that we haven't touched upon, but maybe it's going to be touched on the CME course, is, and Sandy Chung brought this up at the PMI meeting in New Orleans. Her practice has 300 clinicians in the DC metro area. they have trained with ECW, so they have a trained AI model that now does all the coding for the notes. So the physician doesn't have to be doing the monkey stuff anymore. Like, oh, I put, the vaccine was administered, so make sure you charge for the vaccine administration fee. Parent refuses vaccine, so make sure you use the new CPT code, to 3 minutes of counseling. We asked about depression, so make sure you put the G code depression negative. The AI does all of that. And she said one of the fascinating things that they found is that the AI is, I'm going to say it wrong, but I don't know how to say it. It's upcoding, which is a known phenomenon. Physicians downcode because they feel bad they empathize with the patient and they're concerned about the cost of the care to the patient. So they psychologically downcode the visits inappropriately. The AI doesn't have a connection with the patient, so it codes it at the proper level of care, which is an upcode. And but very interesting. I think that's a phenomenal use. And I think it's also a phenomenal use for once I'm done with the AI, ambient AI generated note, if it dropped into something like open evidence, and it cleaned it up to make it a nice soap note from the evidence it got, and then it says here are possible care gaps. That I think would be incredibly useful if it's automated. Then it's a clean note. I can see it. And open evidence can follow patient, so it'll know what the age of the kid is, everything. That will be phenomenal because then the note will be clean and I'll see my care gaps immediately. And I can say, yeah, I want to address that, or no, I don't want to address it. That will expedite, make it more fun to practice and giving more time to be with the patient and not doing scribe work, which is frustrating.
I think it's going to be touched on because that session is being done by Chip Hart. So I know he's.
Chip Hart. Oh my God. Although I have more energy than Chip now.
Yeah.
Well, yeah, Chip Hart's phenomenal. People, if you have a chance to listen to him, you should listen to him. Anything else that we need to touch upon, Randy, is the conference or AI or the future of education and medicine?
No, I mean, I think one way which was mentioned earlier, people ask all the time, is it are physicians gonna be replaced by AI I would say no. I think people who know AI will be replacing people who don't know AI, but you have to know it and you have to use it judiciously and wisely. And I think there's a lot of great use for it, even in medical education. It can act as a tutor, it can act as a patient simulator, it could act as a giving feedback. It could help with that as well, even in education. In publishing, it is helpful in a lot of journals now moved, like, for example, Lancet started out back a few years back, they did not allow AI at all. And now slowly and the instruction to authors, they are actually allowing AI as long as it's being disclosed. And some journals have a certain tier. So if you used it for like a grammar check or like a regular where you did not have AI, create any of the content, it's like a tier 1, which is basically ethically okay. And then tier 3, which is basically everything was started, they started with a blank slate and AI generated everything. And then in between, and those really, so tier 3, it needs to be probably like almost like you check for plagiarism, basically the same way. You might not publish that article. And then tier 2, it can be negotiated. You have to review it. You have to make sure that the content is valid. And then so there is a role for it that in being introduced, but it has to be introduced in a more legal and ethical way that actually the reader is able to trust that this was actually somebody's research, somebody's experience.
You know what? I think AI is going to bring back the art of medicine into the equation. If you think about it, I could take a blank slate of a painting, a whole bunch of paint or whatever painting, and make a masterpiece. But I don't know how to paint. This is going to be garbage. So a professional artist knows how to take that paint, put it on the slate, and make a beautiful picture. I think that's what we're going to be. We're going to bring the art of medicine back into the into medicine, not just the science alone.
Yeah, absolutely. And definitely a lot of places feel like, even universities feel like banning the use of AI is not really productive because that's going to be the wave of the future. So it's the key is to teach faculty how to use it and incorporate it into their teaching and daily precepting in a way that they still can assess the clinical reasoning of the patient, of the student, give feedback to the student, teach about AI, but we need faculty development, we need policies and guardrails, and we need maybe kind of a good use of it and making sure that it's not being used for, unethical things.
Yep.
Yeah, I am fascinated. So I heard the statement by someone who's in pharma. He says all his JDs, when they hire JDs, they assess their ability to use AI models because it makes the attorney more productive. And if the attorney can't use AI models, then they don't offer them a job. They need still the attorneys, but that they want to make sure they can use the AI models so they're more productive.
As a tool for efficiency.
For a tool, yeah, for efficiency. And then the other one, which is fascinating, we touched upon, is this ability to create fake patients.
Yeah.
And run a model in 2 days with 25,000 patients. If I do A, B, and C, what are the outcomes? And they can now, like the big pharma has these models and they can run stuff through them and it'll take 3 or 4 days to come back with the answer. But they don't have to spend the $20 million on a stage 3 trial to find out that the drug doesn't work. And that, even at a small level, like we talked, like I could see, what am I doing with my asthmatic patients? And if I change this or change that, what would be the difference in outcomes in my patient population, right? And it could spit it out in a day. And I think that's very powerful because doctors want to do the right thing. And if I can see it in a model, not just on a paper, I'd be like, oh, shoot, I better start doing that, right?
Yeah.
Fascinating. Well, thank you so much for your time. It's always a joy to see you.
Same here. Thank you so much for having me.
Best of luck in the meeting in March, and I'm so sorry I won't be there, but hopefully I'll be there next year.
So we'll miss you there. Thank you. Enjoy your time in Medellin.
I will text you pictures, I hope.
Yes.
Bye.
All right.
Bye. Thank you so much.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.